You hear the term PTSD thrown around everywhere these days, right? But today, we're stepping away from casual conversation and diving straight into the clinic. We're going to explore exactly how psychiatrists define, cluster, and formally diagnose post-traumatic stress disorder using rigorous medical criteria. It's a complex clinical journey, and understanding it is absolutely crucial. So, let's get into it.
Which brings us to the core question of this explainer. How do psychiatrists actually make this formal diagnosis? You know, experiencing trauma is unfortunately a pretty common part of the human experience. But developing clinical PTSD, that's a highly specific, profound neurological and psychological reaction. It really requires a meticulous, evidence-based psychiatric lens to identify and treat properly.
Okay, let's dive into this. Here's our clinical roadmap for today's diagnostic journey. First, the traumatic trigger. Second, the 4 symptom clusters. Third, screening and assessment. Fourth, differential diagnosis. And finally, medical comorbidities.
All right, starting with part 1, the traumatic trigger, where we define the extreme stressor. Step 1 of any clinical evaluation is establishing the inciting event. A formal diagnosis actually requires an extreme qualifying stressor, but the reality of the numbers here might surprise you. Think about high-risk traumatic events. Around 22% of people exposed to military combat develop PTSD. For survivors of sexual violence, that rate is 11.4%. We also see it frequently following severe traffic collisions. And surprisingly enough, because it happens so often, the unexpected death of a loved one actually accounts for roughly 20% of PTSD cases worldwide. But notice what these numbers are really telling us. While so many people experience these severe traumas, the development of clinical PTSD is actually the exception, not the rule. Most folks who experience traumatic events do not go on to develop the disorder.
In fact, despite just how ubiquitous trauma is in human life, only about 3.5% of U.S. adults have PTSD in any given year. And that brings up a really profound question in psychiatry. Why does the brain of one trauma survivor recover, while another's gets locked into this perpetual state of threat? Well, to answer that, we have to look at how the disorder actually manifests in the patient.
Moving on to part 2, the 4 symptom clusters which form the DSM-5 core.
Okay, picture a realistic clinical scenario for a second. Imagine a patient who survived a severe, life-threatening car accident. If they have PTSD, a psychiatrist is going to look for symptoms across 4 distinct clusters. First up is re-experiencing. The patient doesn't just remember the crash, they suffer from recurrent nightmares or vivid flashbacks where their body literally feels like the crash is happening right now. Second is avoidance. To cope with that, they strictly avoid driving, or they'll even dodge conversations and thoughts related to cars entirely. Third, negative cognition and mood. The trauma alters their baseline state. They might feel this pervasive guilt, emotional numbness, or a totally distorted sense of blame. And fourth, arousal and reactivity. Their nervous system is just stuck in overdrive, they're hypervigilant, easily startled, and locked in an exhausting fight-or-flight response. Now, to meet the DSM-5 criteria, a patient must present with symptoms from all 4 of these clusters. Now, sometimes that avoidance cluster takes an incredibly profound form. In some typical cases, patients might even exhibit dissociative amnesia. What happens here is the brain essentially represses the memory of the traumatic event completely. They have the physiological reactivity, they have the negative mood, but a total inability to consciously recall the actual extreme stressor that kicked it all off.
Which brings us to part 3, screening and assessment, or the clinical evaluation.
So how do we measure this? Evidence-based assessment relies on a solid multi-method approach. Clinicians might start with screening instruments like the PC-PTSD-5 or the PCL-5 checklist just to monitor severity. But to give an official diagnosis, they rely on comprehensive, structured evaluations like the CAPS-5 clinical interview. This ensures absolute accuracy and really helps the clinician map out the exact severity of those 4 symptom clusters we just talked about.
Next up is part 4, differential diagnosis, where we draw the clinical boundaries.
You know, making a diagnosis is just as much about identifying what isn't there as what is. And this brilliantly illustrates one of the most vital boundaries a clinician has to draw, the boundary of time. If a patient presents with severe trauma symptoms just a week or 2 after an event, they're diagnosed with acute stress disorder. Honestly, it is entirely normal for the brain to be heavily dysregulated immediately following trauma. But for a diagnosis of full-blown PTSD, that clinically significant dysfunction must persist for longer than 1 month. The clinician also has to separate the nature of the symptoms from other overlapping psychiatric conditions. Take obsessive-compulsive disorder, or OCD, for example. Both PTSD and OCD feature severe intrusive thoughts, but they differ fundamentally. In PTSD, the recurring intrusive thoughts are directly tied to a specific past traumatic event. In OCD, those intrusive thoughts are not anchored to a specific real-world trauma. Differentiating these is absolutely key to unlocking the right treatment path.
So what happens if a patient suffered a severe trauma and they are really struggling, but their symptom pattern doesn't quite fit those rigid 4-cluster DSM-5 characteristics? Well, in that case, a psychiatrist might formally diagnose an adjustment disorder. It's a way to validate that the extreme stressor caused significant distress while still maintaining the precise clinical boundaries of PTSD.
And finally, Part 5, Medical Comorbidities, Exploring the Multisystemic Burden. Here's the thing, PTSD rarely exists in a vacuum. So, the crucial point is that over 50% of patients with PTSD have co-occurring anxiety, mood, or substance use disorders. It's incredibly common for someone suffering from unmanaged hyperarousal to turn to alcohol or substances just to numb their nervous system. Plus, trauma survivors often develop major depression alongside it. Treating PTSD effectively almost always means you have to address these overlapping, comorbid disorders simultaneously.
And we actually see this burden physically in the patient's biology. Have you heard of the hypothalamic, pituitary, adrenal, or HPA axis? It's the system responsible for coordinating the body's hormonal response to stress. Well, in PTSD, this system shows profound abnormalities. In a typical fight-or-flight response, your body pumps out both adrenaline and cortisol. But PTSD patients often show a paradoxical, hypersensitive HPA axis. This results in uniquely low baseline cortisol, but chronically high levels of catecholamines, like adrenaline. Basically, their physiological brake system is effectively broken.
Now, let's take a quick look at how this understanding has built up over time, because the psychiatric view of trauma has dynamically evolved. Back in 1952, the DSM-I called it gross stress reaction. It wasn't until 1980, heavily influenced by the aftermath of the Vietnam War, that the term post-traumatic stress disorder was formalized in the DSM-3. Fast forward to 2013, and the DSM-5 realized it shouldn't just be grouped with general anxiety, reclassifying it entirely into a brand new category of trauma and stressor-related disorders.
And that evolution is continuing globally right now. The World Health Organization's ICD-11 manual is evolving to officially propose a distinct subgroup, complex PTSD, or CPTSD. This is a monumental shift. It's designed to properly account for the immense layers of trauma seen in survivors of prolonged, repeated traumatization, like childhood abuse or captivity, where there literally was no chance of escape. That kind of trauma leads to unique symptoms, like the loss of a coherent sense of self.
But even with all these clinical advances, we have to look at the bigger picture. Cultural and medical anthropologists are actually challenging the field, pointing out that our clinical rubrics are heavily based on a Western Euro-American paradigm of psychology. They're questioning if these criteria fully capture global idioms of distress. For example, in Nepal, ethnopsychology studies show that trauma is often expressed through the concept of pita. This encompasses profound suffering, but it carries unique cultural stigmas that the DSM simply doesn't account for.
Which leaves us with this final, provocative thought. We've seen the precise, rigorous criteria psychiatrists use today, from those 4 symptom clusters to the actual biological markers. But as our clinical understanding continues to evolve, does a manual like the DSM truly capture the vast global experience of human trauma, or just our current cultural lens on it? It's a fascinating question, and one that continues to drive the very future of mental health research. Thank you so much for joining me on this deep dive into the clinical reality of PTSD. Keep questioning, keep learning, and I'll catch you in the next explainer.